Hello, friends. Welcome to today's program. I'm Dr.Prashant. I'm organizer of this CME, and we have Dr. Jagmohan Sidhu, who is our presenter today. Dr. Jagmohan Sidhu is the medical director and chairperson of Department of Pathology and Laboratory Medicine at UHS Wilson Medical Center in Binghamton in USA, New York, and he is also professor of pathology at SUNY Upstate Medical University. Dr. Jagmohan Sidhu has presented many seminars, done a lot of research work and a lot of teaching in the hematopathology. He's the most senior hematopathologist at his center, and he has done tremendous work in education. He has visited India many times along with me, and we have done many presentations together. So I'm very, very happy to have Dr. Jagmohan Sidhu. Thank you, Dr. Jagmohan Sidhu, for giving your valuable time.
Okay, thank you, Prashant.
Thank you so much. Now,
Yeah,
all our participants, can you hear us and can you see us clearly? Is the sound and the screen is clear for you? If you can see it, please type yes in your chat box. Yes, thank you, Dr. Sridevi. Thank you so much. Thank you. Thank you, Dr. Pavni. I'd like to welcome Dr. Anupam, Dr. Bharti Devre, Dr. Pinky Devi, Dr. Pooja, Dr. Emelissa, Dr. Lakshmi, Dr. Raja Lakshmi, Dr. Sidhu Dyer, and so many others who are joining us today. Thank you so much for joining us. And I will hand over the microphone to Dr. Jagmohan Sidhu. And during the presentation, if you have any questions or comments, please type in your chat box and we will discuss those questions at the end of the presentation. Thank you, Dr. Sidhu. Over to you.
okay, thanks, Prashant. Thanks for that introduction and thanks for the opportunity to share these interesting cases. So I have 4 cases in my lecture. I'll cover first 2 in detail, and if we have time, we will go to number 3 and number 4. Okay, case 1. 27-year-old male presented with abdominal discomfort, nausea, vomiting, and shortness of breath. He had a history of Crohn's disease. His LFTs were elevated and had 38.7 thousand WBC count, marked thrombocytopenia, palpable splenomegaly, and no palpable lymphadenopathy. CT scan of abdomen and pelvis had marked hepatosplenomegaly. Now, we did not know this when the peripheral blood smear came to us. Only thing we knew was patient has this high leukocyte count. All of this information came afterwards, like hepatosplenomegaly and no lymphadenopathy. The peripheral blood smear looked like this. The cells of variable size and shape with numerous cytoplasmic vacuoles, some nucleated RBCs. Actually, there were many, only one is seen here. So what we were thinking, it's either leukemia or some kind of lymphoma coming into the blood. So there were 45% cells like this in the peripheral blood. This is hepatosplenomegaly. And we did flow, and I'll show you the list of the markers that were positive, CD2, 3, and 7, but no other T cell marker, no B cell marker. CD19, 9, DEM positive, CD16, DEM positive, and TCR alpha beta was positive. CD34, CD1A, CD30, TDT, CD56, and CD57 were negative. Now, at this point, because it is like a T cell leukemia lymphoma process, I asked the history Actually, Crohn's disease we knew by then, but then I asked for TNF alpha inhibitor therapy. And I was told no TNF alpha inhibitor therapy, but he did get azathioprine for a few years. Now, do you have anybody with the possible diagnosis? Because I had given them the diagnosis at this point. Bone marrow was done right away within an hour, and it had a dry tap, very small crushed biopsy, and aspirate clot was received, and touch imprints were pretty good. They showed cells similar to those in the peripheral blood, but they looked more like blasts, like a leukemic blast in the touch imprints. In the peripheral blood, they looked more like lymphoma cells. So this was the biopsy. Only thing there I could see was that these few aggregates of cells, rest of it was kind of crushed. The patient was very obese. Because of that, it was hard to get the biopsy, a good core biopsy. So under high magnification, you can see looks like there are endothelial cells covering these clusters of cells. They have large lymphoid cells in them, or large cells in them. Under high magnification, that's what they were looking like, large cells. Aspirate clot, same kind of cells. We did stains on the aspirate clot, CD237, which were positive by flow or positive by immunohistochemistry, and everything else was negative. All T cell markers were negative, no B cell marker. TIA was the only cytotoxic granule protein that was positive. And I was trying to look for CD31 positive cells around the core biopsy. Couldn't see them in the core, but in the peripheral, in the aspirate clot, the tumor cells were positive for CD31. P53 was also more than 50% cells had positivity. Those were the negative stains. We did ISH for EBER, that was negative. Flow was done on bone marrow aspirate, which was kind of peripheral blood. It was all very hemodiluted. That same findings that we had in the peripheral blood. The TCR gene rearrangement study showed both beta and gamma clonal gene rearrangement, TCR gene rearrangement. FISH was done on the bone marrow aspirate specimen. You see, this is a normal cell. It is for chromosome 7. Red is for the long arm of the Q3, one part of the long arm. And green is, which looks a little pink, yellowish here, but it's green. For the short arm, 1, P11. So 2 short arms, 2 long arms, that's normal. But here, 1 short arm, 3 long arms. 1 short arm, 3 long arms. It means there's a loss of 7P and gain of 7Q. So when that happens, you have to think of isochromosome 7. So there are 2 long arms sticking to each other, and P was lost and another Q was gained. And chromosome analysis confirmed that. You can see the isochromosome 7. There should be P here, but there's no P, both are Qs. And then trisomy 8 and loss of Y chromosome. We did NGS, next generation sequencing, by using a 128 gene panel. So it doesn't have all the genes, it's not whole exome sequencing. So just targeted gene panel and found these mutations of clinical significance: ATM, JAK1, JAK3, and KMT2D. The diagnosis is leukemic hepatosplenic T-cell lymphoma of alpha-beta type. Treatment: 6 cycles of hyper-CVAD were planned, but after first cycle, he developed neutropenic fever, CSF was involved, and he could not complete chemotherapy and died. It was like within a month of presenting, or even shorter than that, within a few weeks. What is hepatosplenic T-cell lymphoma? It's small to medium-sized, immature, cytotoxic gamma delta T cells, which are normal residents of spleen. That's what the cell of origin is. Rarely it can be alpha beta type. They infiltrate the sinusoids of liver, spleen, and bone marrow. And no lymph nodes are enlarged. And also, peripheral blood is not involved until later stages, the last stage. It's very rare, less than 1% of all lymphomas. About 200 cases of hepatosplenic T-cell lymphoma have been described. Most of them are of gamma delta type, only a few are of alpha beta type. Patients are usually under the age of 35 years, and they are more often male patients. Highly aggressive, less than 2-year survival. Now, we don't know since when he had been having this lymphoma. He presented to us at a very late stage. 20% cases occur in chronic immunosuppression or immune dysregulation. So he did get azathioprine for a few years. And it presents with a triad of B symptoms, hepatosplenomegaly, and pancytopenia. And we had most of that. Usually no lymphadenopathy, no lymphocytosis, leukemic only in the late stage. The rarity of this disease, along with lack of nodal involvement and presenting symptoms that mimic different entities, including infectious etiologies, make this lymphoma a significant diagnostic challenge. It becomes easier if it involves blood, but that is usually not the case. And the most common cytogenetic abnormalities are isochrome 7, trisomy 8, and loss of Y chromosome. We had all of them. And then various genes are involved, which affect various pathways. And isochrome 7 has an oncogenic role. No established optimum chemotherapy because very few cases, nobody can do really a big study on them. So chemotherapy followed by stem cell transplant has been tried, but the data is scarce given the rarity of the disease. So it's possible in future we will have some novel targeted therapies. Interesting features of our case. Leukemic presentation of hepatosplenic T-cell lymphoma that is mimicking acute leukemia. And there are 2 papers in the literature that are like this, where they say it just look like acute leukemia. One of them is from New York City, Cornell. That's a more recent paper. And their case just looked like acute leukemia. And they had a hard time making the diagnosis. Second interesting feature that it occurred in a patient who was younger than 35 years of age and a male patient, history of inflammatory bowel disease, was on immunomodulatory therapy for few years, I think 2 or 3, he was on. Hepatosplenic T-cell lymphoma of alpha beta type. I don't think any case of alpha beta type has been described with those cytogenetic abnormalities, with combination of all of them. They are more often in gamma delta type, but we have them. CD16. We had CD16 expression, and CD16 is a spleen homing antigen, so it could be involved in taking the cells to the spleen. And CD31 expression. Now, that has not been described in hepatosplenic T-cell lymphoma, but it has been described in other T-cell lymphomas and in mantle cell lymphoma. And it's considered to be cytoprotective due to inhibition of apoptosis, and it helps promote the lymphoma development. And also it confers chemoresistance. And CD31 on lymphoma cell, CD31 on endothelial cell, they could be working with each other to have this sinusoidal involvement. So CD31 also has suppresses the anti-tumor T-cell responses. JAK1, JAK3, those were the mutations we found in our case. They have been described recently to be involved in pathogenesis of this lymphoma. In this picture, interleukin-9 binds to interleukin-9 receptor, and then JAK1, JAK3 are activated. They activate different stats, so JAK-STAT pathway, and that leads to cell proliferation. Other pathway is RAS, RAF, MEK, ERK pathway, which is not involved in our case. That's what we are saying, that there's involvement of ATM gene, which is also, that leads to loss of repair of the mutated cells, so they keep circulating, acquire more mutations. And then this JAK-STAT signaling pathway is involved. So that is considered to be important in pathogenesis of this lymphoma. These are the references. And the second case was a 70-year-old Caucasian male. That is important. It's a white male presented to the emergency department with 1 week history of progressively worsening vague abdominal pain, bloating, and lack of appetite. He denied any fever, chills, or weight loss. Physical exam, including ENT exam, that is important too. No hepatosplenomegaly, no other abnormality, and physical exam was normal. Absolute lymphocyte count, about 6,000 lymphocytes. Thrombocytopenia, mild leukoerythroblastic picture. Elevated AST, ALT, alkaline phosphatase, lactic acid, and markedly activated LDH. Abdominal ultrasound showed an edematous gallbladder wall, and because of that, he was diagnosed as like acute cholecystitis, causing all of those symptoms: abdominal pain, bloating, lack of appetite, and antibiotics were started for presumed acute cholecystitis. And CT scan of abdomen showed mild splenomegaly, 13 cm maximum span. It wasn't a big spleen. Peripheral blood. Now, same kind of cells that we saw in the previous case. Here, some of them have granules in them, but they are of variable size, shape. Nuclear condensation is variable, like some are less condensed, others are more condensed. But usually, most of them were like more condensed than what we see in blasts. So again, the question was, is it acute leukemia or lymphoma involving the blood? More of those cells Flow cytometric analysis. CD2 and 7 in the second picture, they are co-expressed. CD56 is expressed on those cells. No surface CD3, no cytoplasmic, no surface CD3, and no CD16. And there was no CD57. CD2, CD7, CD56. Others were negative. Surface CD3 was negative. But was it? Yeah, surface CD3 here. It is negative. CD4, 5, 8, 16, 57, they were negative. No B cell antigens, no myeloid antigens. Same thing on the previous case. We did all myeloid antigens too. They were negative. So that's what we thought it is, aggressive NK cell leukemia. Because of the phenotype and the morphology of these cells. Bone marrow was done again within an hour or two, and cells looked again more like blasts in the bone marrow than in the peripheral blood. Core biopsy, lymphoid aggregate, big cells that mixed with some erythroid precursors, CD2 positive, CD3 and CD7. Now, CD3 is positive by immunohistochemistry. It was negative by flow because we didn't look for cytoplasmic CD3 by flow, which we usually do, but somehow we didn't do it. And then immunohistochemistry shows CD3 cytoplasmic. That's also is seen in aggressive NK cell leukemia. CD56 positive, and all cytotoxic granule proteins were positive. P53 MYC, both more than 50% cells. PDL1 was done for a reason, because PDL1 is usually overexpressed in aggressive NK cell leukemias. I'll talk about that later in the maybe last slide. P67, almost every cell was positive. EBER, very strongly positive. But EBV LMP1 was negative, which means it is latency type 1, which is usually seen in bucket lymphomas. So EBV LMP was negative, EBER was positive. Flow cytometric analysis. The bone marrow, actually same thing as in blood, 2, 7, and 56. And we did cytoplasmic CD3 on the bone marrow aspirate, which was negative, maybe a different antibody that didn't stain the cytoplasm. So TDT negative, alpha, beta, gamma, delta also negative, because CD3 is not expressed, they cannot be expressed. The diagnosis, aggressive NK cell leukemia, and we had sent blood for serum, for quantitative PCR for EBV, which was positive. Upper limit is 1 million copies per milliliter, and there were more than 1 million copies. He died on day 2 of admission, but within 4 or 5 hours of doing bone marrow. And autopsy was done, which was limited to chest, abdomen, and pelvis. And what we found was splenic rupture and bleeding due to spontaneous splenic rupture. This is spleen, same kind of cells, not as well preserved as in the bone marrow, but they had similar immunophenotype, EBER, and liver had also infiltrates which showed same immunophenotype, and lung had intravascular lymphoma cells with same immunophenotype. Other organs had little bit, but not too much parenchymal involvement, mostly in the blood vessels. Even kidney had glomeruli filled with those lymphoma cells. It was almost in every organ because it was present in the blood vessels, not in the parenchyma of the organs. Chromosome analysis, 4 abnormalities. First one, which is pink, is the additional material on chromosome X. Second one, loss of Y chromosome. Third one, 4-8 translocation. And the fourth one, isochromosome 7. This is the first picture is say isochromosome 7, this 8 and 4 translocation, extra material on X, and no Y. And there was a second clone, which was actually tetrasomy of the first clone. TCR for T cell gene rearrangement. So no TCR gamma rearrangement, but clonal T cell receptor beta rearrangement was positive, which can be seen in aggressive NK cell leukemia. In the gene panel, NGS showed 3 mutations, KRAS, TP53, and TET2. So that was the final diagnosis. And there's one case report of aggressive natural killer cell leukemia with jaundice spontaneous splenic rupture. Why splenic rupture occurs? Because of 2 reasons, possible two reasons. One is lymphoma cells infiltrate the parenchyma and stretch the capsule, and capsule ruptures. In our case, there wasn't spleen wasn't very big. So the second possibility is coagulation abnormalities occur in these lymphomas. There could have been thrombosis, necrosis, and then rupture. That's what I'm saying here. Okay, so what is aggressive NK cell leukemia? So systemic proliferation of NK cells, usually EBV positive. 0.1% of lymphomas are aggressive NK cell leukemias, lymphomas and leukemias. Less than 300 cases have been reported or published. It occurs usually in Asians, and average age is like 40 years, more often in men than in women. Less than 3 months median survival, very fulminant course. There's a cytokine storm. NK cells, though, they release cytokines. And there is a triad of fever, hepatosplenomegaly, pancytopenia. And then cases can have hemophagocytosis, DIC, multi-organ failure, and death. Morphology of the cell, they're quite variable. And features of aggressive NK cell leukemia overlap with the advanced stage of extranodal NK T cell lymphoma. It can be very hard to differentiate between the two. So I sent it to an expert for his opinion, and he agreed that we should call it aggressive NK cell leukemia. So there are chromosomal gains, losses, recurrent genetic aberrations, and involvement of various signaling pathways. There's no established optimum chemotherapy. New targeted therapies, JAK2, BCL2, Aurora kinase inhibitors, and immune checkpoint inhibitors. Aggressive NK cell leukemia can be EBV positive. Usually it is positive, and most of those cases are de novo. And rest of them evolve from EBV positive NK T cell lymphoproliferative disorder. a low-grade disorder that becomes aggressive. So those young patients who have this ANKL, they most probably have evolved from this chronic NKT LPD. About 10% cases are negative for EBV. Now, what are those cases? Those are actually progression in probably, most probably, Dr. Jeffy, Elaine Jeffy has published that. That is probably progression in NK type large granular lymphocyte leukemia. They become large cell, it's a large cell transformation in LGLL, NK type. There are entities that we should think about before calling it aggressive NK cell leukemia. One of them is hepatosplenic T-cell lymphoma. Why? Because hepatosplenic involvement in ANKL and isochromosome 7. Isochromosome 7 was considered kind of diagnostic of hepatosplenic T-cell lymphoma until it was found in other T-cell leukemias and lymphomas. And there are some overlapping mutations, but how to differentiate? Hepatosplenic T-cell lymphoma has sinusoidal pattern of involvement and has surface and cytoplasmic CD3 expression, but ANKL doesn't have surface CD3. And both have clonal T-cell gene rearrangement. There's another entity which morphologically doesn't look like this, but because the morphology is so variable, some cases can look like a blastoid, blastic plasmacyte or dendritic cell neoplasm. About 8% of them are CD4 negative. So it's usually CD4 positive, but 8% can be negative. And those who are negative, they have CD2, 7, 56 instead of CD4, CD56. They have CD2, 2, 7, 56, and overlapping mutations. Now, how do we rule it out? Clinically, most cases present as skin nodule, and then they can involve blood. But some cases can occur like in bone marrow and blood. The morphology is different. They look like blasts. And CD123, 4, 56. So one way to easily remember this is CD1, 2, 3, 4, 5, 6. So those three markers are usually positive in it. CD303, CD304, TCL1, TCF4. Usually we don't need them. But TCF4 is positive in 100% cases. A dot like CD68 positivity, E cadherin is positive in these cases. And there's no T cell receptor gene rearrangement. So the third entity, which is difficult to separate from ANKL, is extranodal NKT cell lymphoma, non-nasal type. Because nasal type, you know, there's a nasal, destructive nasal lesion. That's why I said ENT exam was normal. But it can be non-nasal type. Why do we have to consider it? Because kind of similar looking process, EBV association, and cells can look similar. Involvement of peripheral blood can occur, but there are some other clinical differences. But in the advanced stage, it's hard to separate it from ANKL. How do we rule it out? It can be difficult. Now, next 3-4 slides are very busy looking slides, but I'll try to make them very simple for everybody. Now, this one is a differential diagnosis between ANKLL and extranodal NKT cell. It's a typo. It should be ENTK, not ENKT. CL, non-nasal type. Anything that is in red and is bolded is shared by these two entities. So you can see how much similarity is between these. And anything that is bolded blue has some differences. And the differences are not very strong, except organs involved. Extranodal NK cell involves skin and or soft tissue or GI tract or testicles. But liver, spleen are far less often involved. Peripheral blood and bone marrow is involved at a later stage. So immunophenotypically, not a real difference. Some chromosome abnormalities are different, but most of them are the same. Same thing with the array CGH. There are more abnormalities in ENTKCL than in ENKLL. Gene rearrangements, they may or may not be present in ENKLL, but they say when you have TCR beta, you always have TCR gamma rearrangements in ANKL. Extranodal NKT cell, they say you can have T cell beta rearrangement without TCR gamma. In our case, I think that feature helps us calling it ANKLL. And in our case, we had beta without gamma. It was more like extranodal NKT cell. But again, it's a combination of all the features before you make the diagnosis. But you still think that it could be extranodal NK T cell leukemia lymphoma. Now, this slide shows you the comparison of the mutations. Anything in red is shared by both entities. And anything in purple is actually unique to those entities. Chat2 has not been described in TKCL and TKCL, but it can occur. It's not a really differentiating feature. We need another paper that shows that it can happen in both entities. TP53 is both have it. KRAS, these are the three mutations that we had in our case. KRAS can occur in both. TP53 can occur in both. TET2, so far, it's only in ANKLL. And those that are, and this is another paper showing the same kind of overlap of mutations. Now these three mutations occur only in extranodal NKT cell so far. And this may become, actually, with additional papers, this may also become not a differentiating feature. In our case, our panel did not have everything. Anything in these red, you can say lines, these were not part of our panel. For that, we have to do whole exome sequencing. Other than Notch2. Notch2 was the only one that was in the panel, but we didn't find any mutation in that. That's what I'm saying by these red circles. Another paper that is published recently, 2018, that talks about these all types of mutations. Now we have mutations in 3 pathways, but not in JAK-STAT pathway. And it is mentioned in this paper from 2018, Cell research paper, that even if there is no JAK-STAT pathway genes, STAT3 activation occurs by other mechanisms in ANKL. So JAK-STAT pathway is always involved, even without the mutations. Another paper talking about same kind of mutations, and we do have TAT2 and TP53. These are in extranodal NKT cell. So 3 pathways, JAK-STAT, MAPK, and NF-kappa-B are involved in ANKL. Now, this paper talks about mutations in PDL1 and PDL2. If we look at ENKTL and ANKLL, Red is the mutations in the PDL1, and there are amplification. Green is amplification. So about 20 to 25% cases have amplifications of PD1, PDL1. Others have mutations in it. All of that makes overexpression of PDL1 in anaplastic large cell lymphoma and other EBV-related tumors. But we did PDL1 and it was negative. Means it doesn't happen in all cases. Also, we didn't have PDL1, PDL2 genes in our gene panel. But negative PDL1 expression actually tells us there is no mutation in those genes. And this paper talks about these two KMT2D and TET2 mutations. If you have them, it's a prognosis is bad. This paper actually talks about that latency type 2 and latency type 1 of EBV. Latency type 1 has no LMP1. We did not have that in our case. That's why the lymphoma cells, they can evade the host virus specific cytotoxic T cells. In those cases who have LMP1, they're latency type 2. Now, what happens, there are two possible mechanisms of development of this lymphoma. One involves NF-kappa B and AID activation. EBV does these three things. We don't have LMP in our case, but upregulation of TNF-alpha and these CD markers, that leads to NF-kappa B pathway activation, which increases leukemia cell survival. Upregulation of AID, that enzyme activation induced cytidine deaminase. If it is forced, if there's a forced upregulation, like in this case, that makes NF-kappa B keep going. So that's how this vicious cycle develops, and we get this lymphoma or leukemia. The second pathway, which is very new, is a interleukin 10, STAT3, and MYC biosynthesis pathway. There are two types of ANKLs. One that has JAK-STAT pathway mutations. Our case doesn't belong to that. But others with TET2 and TP53 mutations. Our case has that, without any JAK2, JAK-STAT pathway mutations. In both cases, EBER, which is present in because of EBV, EBER1 increases interleukin 10 expression. So that leads to increased pSTAT3. So JAK-STAT pathway is activated. pSTAT3 binds to MYC, increases glycolysis, increases nucleotide synthesis, and more cells are proliferating. So leukemia cell survival and proliferation. So this is the mechanism that we had mentioned in previous slide, that even without JAK-STAT pathway mutations, STAT3 can get activated by other mechanism, and this is the mechanism. And this is a little thing about LMP. Why don't we have LMP? Because most of the cases have LMP1. They say the cytotoxic T cells can cause mutational deletion of LMP1 in these cases. That is the explanation for absence of LMP1. I can go very quickly in 5-6 minutes over two other lymphomas, which is much shorter presentation. This patient came 80-year-old Caucasian male of East European origin, came to emergency department with a few days history of tender lumps in right side of neck, both armpits, and night sweats. Physical exam, bilateral cervical axillary lymphadenopathy, no hepatosplenomegaly, no other abnormality. Leukocyte count was very high, 116,000. Normal platelet count, normal hemoglobin hematocrit, markedly elevated LDH, 4.4 centimeter lymph node. One of them is 4.4 centimeter in the mediastinum. No other lymphadenopathy. And the peripheral blood, it looked like this. See, the cells are folded, they are becoming horseshoe shaped, they have multiple lobes, very abnormal looking, and the machine was counting them as monocytes. We did flow cytometry on this, and 50% cells in the blood had CD2, cytoplasmic CD3, no CD25, but CD30. CD2, CD3, CD30, no other T cell markers, no B cell, no myeloid. 25 was negative. This is the bone marrow. These are those hallmark cells. Not that many, but they were there. So what is the diagnosis? With immunohistochemistry, same results. ALK, we did ALK1. That was negative. So did P63, which was positive. Gene rearrangement, positive for TCR gamma, not for TCR beta. And then we did FISH for DUSP22 and TP63. Both were negative. It's ALK negative, DUSP22 negative, TP63 negative. It's a triple negative case. And the karyotype, I didn't even really seriously looked at it. Everything looks bad. 128 gene panel, it has these 5 mutations of clinical significance. TET2 is there, TP53 is there, PRDM1 and PIK3CD and JAK3. Leukemic ALK negative anaplastic large cell lymphoma is a triple negative. Now, cells can look like those flower-shaped nuclei in ATLL, adult T cell leukemia lymphoma. CD25 is almost always positive in those cases, and it was negative. 6 cycles were planned, but he died a day after initiating chemotherapy. And last case, 84-year-old Caucasian male presented to the emergency department with bloody diarrhea and generalized weakness. First thing they did was COVID test, which was negative. He had multiple comorbidities, diabetes mellitus with really bad heart, lung, kidney, CNS issues. Physical exam, no hepatosplenomegaly, no lymphadenopathy. Absolute lymphocyte count, 8,500 per microliter. Platelet count was slightly high, but there is also microcytic hyperchromic anemia. So that could be due to microcytic hyperchromic anemia, because he has been bleeding. These are the cells in the peripheral blood. They have little immature chromatin. You can see 1, 2, 2, 3 nucleoli. They're faintly visible. They are not. The cells are not very big. You compare it to the red cells. Maybe they are 2 times the size, not more than that. And they have these cytoplasmic blebs. 2, 1, 2. Here, rabbit ears. So CD2, 3, 4, 5, 7, all positive, no CD8. It was a pure CD4 population. CD25, 26 positive. Usually in these cases, CD26 is negative, but it was positive in this case, and they were all of TCR alpha beta type. Bone marrow was done, which shows CD3 positive cells like scattered in the bone marrow with similar kind of distribution by TCL1. Gene rearrangement, clonal beta as well as gamma gene rearrangement. There was loss of ATM gene. We did fish for CLL because that panel includes ATM and TP53, and both of them can be lost in this entity. But ATM is almost always lost. No other chromosomal abnormality. Gene panel showed these two mutations in SAMHD1 gene, which is also seen in this entity. Not in all cases, but some cases. So T pro-lymphocytic leukemia, small cell variant. This is an image from ASH, that ASH image bank. Dr. Venkataraman Girish is the editor of this page. He has this case of TPLL with cytoplasmic blebs. That's pretty characteristic of these pro-lymphocytes. Now the questions, we have 11 minutes.
Anybody has any questions or comments?
So I can minimize it here.
The chat box, Dr. Sidhu. Looks like there is no question at this time. So I'd like to thank Dr. Jagmohan Sidhu for spending his valuable time. Thank you everybody for joining us today. Could you please, there is a comment here. Thank you everyone. Thank you so much. Rohan is saying that we discuss the pro-faculty approach to anti-cellular plasma and how do you suspect modality of the flow.
Prashant, can you hear me? Yeah, Mohan Sardana has.
There's a comment here.
It's a very complex subject. I don't think most of those antibodies are not even commercially available that can be used to determine clonality. That is a very, very hard thing to determine clonality by flow. Those are KIRs, those antibodies are used to determine clonality. We can talk about, like, if there can be a lecture on that, but I have never determined it by flow, so I can't give you the specifics of which markers can be used and how they should be used. Okay, so is that all?
Thank you, Dr. Sidhu.
Thank you.
Thank you. We'll end the seminar
Super.
here. Thank you.